introduce our speakers. For first talk, that is the managing LDL cholesterol, real challenges and real solutions with inclisiran. I would like to invite Dr. UC Samal, sir. Please, sir. Yeah. Dr. S.S. Chatterjee, sir. Dr. Neeraj, sir. And Dr. Birender Kumar. So I would like to hand over the session to Dr. UC Samal, sir, and Dr. Chatterjee, sir, to introduce our speaker and to start this session. Thank you.
Good evening to whole gathering here, esteemed speakers, also the members of the BIC, Bihar Interventional Council, those who are present here, and of course my fellow chairpersons, Dr. Chatterjee and Dr. Shasan. With this, I have the opportunity and rather privilege to invite one of the best speakers ever I have heard most of the times is Dr. Vivek Kumar. And Dr. Vivek Kumar has a very long and plethoric biodata, and just to be nutshell speaking, he is the Vice Chairman and Chief of Cath Lab, Max Devki Devi Hospital of Cardiac Sciences, and also Interventional Cardiology, Electrophysiology, and also pacemaker. He has a long innings there, almost 26 years. Vivek Kumar is extensive, he has extensive experience in field of cardiac interventions and electrophysiology. He specializes in complex angioplasties, including multivessel bifurcation and left main angioplasties with rotablation, etc. Working experience, Vivek Kumar is currently working at Max Devi. I have said that. He had done large volume of complex angioplasties and valvular interventions. To start his education, he is a graduate of BHU, and subsequently he have done his MD medicine from BHU, then DM cardiology from Kanpur. Subsequently, he had the interest of visiting abroad and worked in St. George's Hospital, London, UK, and Southampton University, particularly in the capacity of interventional cardiology and EP studies. He's got multiple fellowship, and he is a fellow of TAVI, CSI, and also FSCC, American College of Cardiology, ESC, and FSAIC, that is fellow of Southeast Asian Interventional Council Society. And he is also a member of Heart Rhythm Society. He has many awards to which he has been bestowed upon: a Chikitsa Ratna Award of DMA, Vidya Ratna Award, Kanpur University, and International Award of Excellence in Cardiology from Mysore, Mithila Saman from late Arun Jaitley, Minister of Finance and Corporate Corporate Affairs, Dr. K. Saran Cardiology Excellence from IMA, Lifetime Achievement Award from Gastric Society of India, honor from Iraq government from cardiac services. A special interest is that TAVI, structural heart disease, interventional cardiology as a whole, electrophysiology and devices particularly, expertise in procedures like TAVI and structural heart disease, coronary angioplasties, complex angioplasties including multivessel and bifurcation and left main, angioplasties, rotablation, FFR, IVUS, OCT, and also IABP and Impella. Peripheral and renal and carotid angioplasties are also his fanciful way of working. EP study and radio frequency ablation with 3D mapping of valvuloplasty of BMV and PAV has been his hobby. Pacemaker, AICD and combo implantation, he has enough experience, and ASD, VSD closure by devices, vascular closures and leadless pacemakers, subcutaneous ICD, left arterial appendage device closure, aortic stent graft and hybrid procedures also, percutaneous closure devices, LVAD and heart transplant team. He is also member of heart transplant team and ECMO. With these words, I request the speaker to take the dais.
So, good evening, friends, and a special thanks to Dr. Samal for kind introduction, and Dr. Ashish for inviting me, and Novartis for creating the awareness about reducing the most strong risk factor for prevention of coronary artery disease. So, if you look at the LDL cholesterol, that's a real challenge for preventing or decreasing the incidence of cardiovascular complications, and we have now real solutions, and we'll discuss what it is. So if you look at the agenda today, in next 10-15 odd minutes, I'll be discussing about the need for effective LDL reduction. Then what are the patient profile, and we will discuss about the common garden variety of patients, what are the guideline recommendations, and where does this inclisiran as a choice or drug for high risk atherosclerotic cardiovascular disease would fit in, and the final key takeaways. So atherosclerotic cardiovascular disease is a leading cause of cardiovascular morbidity and mortality, and 1 in 10 report a second myocardial infarction, a stroke or cardiovascular death within the first 100 days after experiencing an acute myocardial infarction. So that's a huge healthcare burden, and more than 10% event rate of death, MI, and recurrent acute coronary syndrome reported at 1 year. So people who have got an acute myocardial infarction, they are at constant risk of subsequent event, be it so all vascular event, not only the myocardial infarction but also vascular event like stroke and all. So LDL cholesterol is the top modifiable cardiovascular risk factor. So that has been found, and the good thing is that it's a thing where intervention trials have shown that if you decrease this significantly, the outcomes become better. So what does the real world setting show? A huge gap in dyslipidemia management is there, and need for intensive lipid lowering therapy has to be there. So if you look at the data, which shows that there is a considerable gap in management of dyslipidemia in real world setting, and it highlights the need for a more aggressive approach for the So it also, so if you can see the fail to achieve the LDL goals, almost 80% to 88% in different series, people have failed to achieve the target. So role of earlier combination therapy in high-risk atherosclerotic cardiovascular disease, despite poor LDL cholesterol, 20%, less than 20% of atherosclerotic cardiovascular disease patients in intensified lipid therapy, guidelines still favor a stepwise approach over upfront combination therapy. So time to prioritize early. So if you have hit hard early, so the accumulation of plaque is level of LDL and the number of years one gets exposed to that. So the longer you keep high LDL cholesterol, the higher the chances of cardiovascular event and significant plaque would be there. So starting combination of lipid lowering therapies at diagnosis in high risk patient reduces the treatment delays and ensues faster LDL cholesterol reduction with dual benefit in 4 to 5 weeks. It means that it brings down the LDL significantly low, and it brings out very fast. So it takes hardly a month or half to bring the LDL level significantly lower. So if you look at the real world challenges in achieving LDL cholesterol. Let's go for the real life cases where this is a common garden variety patient, young patient who is very busy with his job, 39 years of age, BMI is slightly on the higher side, male. So this patient is a successful software engineer who works around the clock and leads sedentary lifestyle. He was diagnosed with diabetes 5 years ago. He presented with non-ST elevation mitral infarction and had a drug-eluting stents as young as 39 years in his right coronary artery. And he was on medication of LDL lowering agent atorvastatin 40 and then anti-diabetic medication empagliflozin and metformin. His SbA1c was 6.2 and current LDL is 154 milligram per deciliter. It means that it was way high than what the recommendation says. So the treatment requirement for this gentleman is a robust lipid lowering agent. So if you look at the 2024 ADA standards of care recommendation, the people with diabetes and atherosclerotic cardiovascular disease intolerant to statin therapy, PCSK9 inhibitor therapy, or with inclisiran, siRNA should be considered as an alternative cholesterol lowering therapy. And those who do not achieve the target, then obviously we can use it as an add-on therapy. So inclisiran has shown it provides significant LDL cholesterol lowering, and post-hoc pooled analysis of pivotal phase 3 trial in individual with diabetes, it shows that there is a significant reduction in LDL cholesterol from baseline. So almost 51.9% in diabetic patient, 51.6% those who are pre-diabetic, and also the 47.6% in individual with normoglycemia. So inclisiran provides significant and sustained LDL cholesterol lowering across the glycemic strata. It means that all group would benefit whether the person is diabetic. It's not moving. I think this scroll is not. So there is a 53% significant LDL reduction versus usual care. So whatever the standard of care is right now, addition of inclisiran reduces the LDL cholesterol by 53%. So an inclisiran first implementation strategy was more effective in lowering the LDL cholesterol and led to greater LDL goal attainment than the usual care. So LDL cholesterol goal attainment with inclisiran was almost nearly 75% of the patients would achieve that, compared to the till now just nearly 9% of the patients were achieving that. So inclisiran provides the lowest treatment burden and high potential for treatment adherence. So before we started my talk, I was discussing with Dr. Pramod, there are a lot of patients who come and say that, Doc, I don't have time to take the pills every night, so why don't you give an injection which works for long, so once in 3 months and then once in 6 months you keep on giving, and that will work for me. So definitely the compliance becomes much better. So siRNA, that is inclisiran, is associated with lower administration frequency as compared to PCSK9 inhibitor, which has to be given every 2 weeks. So the compliance is much better with this, and potential for high treatment adherence is there. So majority of the achieved LDL cholesterol goals with inclisiran over an extended term period, which was studied in various Orion trials, and Orion 8 results clearly showed that 78% of all patients achieved the prescribed LDL goal. So it means that this is a drug with which we can achieve a target, and there was almost nearly 50% LDL cholesterol reduction at the in these group of patients. So your atherosclerotic cardiovascular disease patients with diabetes who fail to reach with LDL cholesterol goals can benefit from this. With this, inclisiran can provide sustained and robust reduction, so almost 52% LDL cholesterol reduction in patients with diabetes and pre-diabetes, and high potential for adherence is there, convenience dosing regime, and majority of the patients, nearly 80%, achieve the guideline recommended LDL cholesterol goals with inclisiran. In fact, the Lipid Association of India and the CSI guidelines also, they are much more stricter, and we say that LDL cholesterol should be less than 50, and that can be achieved only when you have these kind of robust molecule. This is another patient which we see that 52-year-old female has slightly on the higher BMI, 32. She experienced non-ST elevation mitral infarction and had to undergo CABG with multivessel disease, and graft was placed. And then the patient was again on LDL cholesterol lowering agent atorvastatin 20 milligram and ezetimibe 10. eGFR was low and the LDL was currently 120. So it means that this patient was again not adequately medicated and had not achieved the LDL cholesterol which is desired. So if you look at the 2024 ABCD and UKKA recommendation, that consideration of inclisiran for secondary prevention in people who fail to achieve the treatment targets, with evidence supporting its use to stage G3B chronic kidney disease. So if you look at the patients who are diabetic, have got chronic kidney disease, they are at a very high risk of atherosclerotic cardiovascular disease, and we need to bring down the targets in them. So inclisiran provides effective LDL cholesterol reduction, and this post hoc pooled analysis of 2 phase 3 trials did show that inclisiran provided effective and consistent LDL cholesterol reduction irrespective of the mitral infarction status. So post MI patient also nearly more than 52% reduction in LDL cholesterol. Even the patient who had a remote mitral infarction, nearly 50% reduction, and no prior mitral infarction, 51% reduction is there. So it means that the sustained LDL cholesterol reduction, and you can see the graph here that there is a significant sustained reduction and up to 510 days. So inclisiran provides effective LDL reduction, and results, again I said that there are various Orion trials, and Orion 7 also showed that from baseline to 60 days you can see that such a quick, within 60 days you have almost 57% reduction in the cholesterol level, and in these cases even if the patient who has had renal dysfunction, the targets were achieved. So if you look at this lady who had to undergo bypass surgery at a very young age, had inclisiran would provide significant sustained LDL cholesterol reduction, more than 50% reduction, and in patients who have got severe renal dysfunction, again there will be 49% LDL cholesterol reduction, and in patients who have got moderate renal dysfunction, there almost 53% reduction would be there. If you look at another real life patient who have 60-year-old male who was slightly on the higher BMI side, had undergone PCI 3 years back, and again you see the current LDL is 80 milligram per deciliter. So we will see that probably this patient is having better than the other 2 patients, but again this is not meeting the target. So this patient would also need the much robust reduction of the LDL cholesterol. So in these patients who have got multiple medications like this gentleman, inclisiran is very safe. So drug-to-drug interaction and the tolerance and the side effects are significantly lesser. So inclisiran is not expected to cause drug-to-drug interaction or be affected by inhibitors or inducers of cytochrome P450 enzyme, and there is no safety concerns also. The tolerance of this drug is very good. It provides long-term safety in high-risk cardiovascular disease patients. And this analysis, pooled analysis is there of 7 trials, nearly, almost 10,000 patient years are there. So there will be fewer events with inclisiran compared to the placebo, very low side effects needing discontinuation, and associated side effects are infrequent and no impact on the safety of the inclisiran. So inclisiran, if you look at the data from Orion 8, there again more than 1,200 120,000 patients of the patient exposure, inclisiran showed consistent and long-term safety and tolerability. So one of the good thing, which is, a lot of patients who do not tolerate the high dose statins and all, this is a drug where it causes, there is hardly any side effect and the effect is quite robust. So in our case, this patient who had got atherosclerotic cardiovascular disease, patients with recurrent event who failed to reach their LDL cholesterol levels can benefit significantly from inclisiran. And the safety profile up till now, we have got maximum 6 years data of nearly 9,982 patient years, so which is very, very large data, and I think that should suffice. So if you look at the 3 case scenarios, like in all these 3 cases, we have seen that they have not met the the targets where it should be. If you look at the Cardiology Society's guidelines 2023, there again the risk assessment wise, all these patients were high risk, and lipids goal were that we have to bring down the LDL cholesterol level to less than 40 milligram per deciliter in extremely high risk group patient, and which was hardly achieved by the conventional drug treatment till now. So in this, inclisiran is recommended by guidelines for patients that it should be given, and that has now come into NICE guidelines, CSI guideline, and ACC/HA guideline. So to sum up, and the key message is that patients who have got very high risk or extremely high risk atherosclerotic cardiovascular disease, the benefit from inclisiran is huge, and we should be using in these group of high risk patients. So key message is that LDL cholesterol reduction is cornerstone of cardiovascular risk reduction, and evidence is showing the greater benefit from early and significant decrease in LDL cholesterol, starting the lipid lowering therapy at a much earlier stage and to achieve the target, and it's achieved the target very early, 4 to 5 weeks, and 2 maintenance doses of inclisiran per year achieves the effective and sustained LDL reduction, and that is what the goal is, to decrease the atherosclerotic cardiovascular disease. So thank you very much for your kind attention.
Thank you, Dr. Viveka, for a very nice lecture on inclisiran. We know that this drug is coming. Of course, we don't have practical experience of this drug because this is hardly available at the moment in Patna, and it's little costlier, but the best thing is that it can be given every 3 months or 6 months or so. I just want to know, do we have any hard point data about the efficacy of this drug on cardiovascular outcomes, not on LDL-C only?
Yeah.
On the cardiovascular outcomes, what is the data available with the inclisiran?
Yeah, so I think the good point is that if you look at the data from statin era till all the lipid lowering agents, there is a significant data that the repeat myocardial infarction rate comes down significantly, and repeat vascular event also comes down significantly. So there is a not only direct but indirect evidence also is there, and if you look at the Orion series data, that is also showing that, and the most cost effectiveness is there in secondary prevention. The patient who had got first episode of myocardial infarction, the repeat event is significantly lower. So that is the most appropriate patient for investing in this therapy is patient who has got familial hypercholesterolemia, those patients who have had intolerance to statin or conventional treatment, and those patients who had a previous cardiovascular event, or those patients who had an intervention at early age, like our patient who had bypass surgery or stent in less than 50 years of age. So I think these are the targets where we must utilize this.
Okay. If there is any question from the audience here.
What do you think? How many percentage of people in India will require these molecules once they are on statins, ezetimibe, and bempedoic acids? What is your experience?
So we have data which shows that the combination. So the people who come under the umbrella of controlled lipids are much higher if you combine ezetimibe, highest dose of high intensity statin and bempedoic acid. So there is a data which shows that the people achieve target, but I still feel that nearly 5% of them would need this treatment, and especially so if you look at the paradox of our country, our patients get cardiovascular event, the commonest age for myocardial infarction is lowest in Indians across the globe, that is 35 years to 50 years. So 50% of the patients will have cardiovascular event in this age group, and if we invest in them, then obviously the second event rate would be lesser. So answering your question, I would say that it is at least 5% of them would need this treatment therapy. Yeah.
Any more? Yeah.
Yeah, so it has, as I showed, that till now we have got almost 6.5 to 7 years data of safety profile, and that has shown that it is the need to discontinue treatment has been hardly any there, so less than 0.1%, and the safety wise, so side effect profile wise, it's very, very good. And since it is a prick in 6 months, so obviously the patient also tolerated well. So safety profile is very, very good of this.
One small question from me.
Yeah.
As we know, this drug is on the works on the receptors, and still the production part of the cholesterol is ongoing. So you have to use this with along with the other anti-lipid lowering agents. You cannot use it alone because the production is there. Even if you modulate the receptors, you got to modulate the production also. So first thing is that using any drug which modulates receptor will translate into the clinical benefit for that time also. But once you withdraw this drug from the treatment, the patient goes to the same risk level. So using this drug in a country where we have a cost constraint and still you have to use statin and other drugs to the fullest so that you can curtail those other mechanisms of cholesterol production. So how can we justify this?
No, so I think that's a very good question. So if you see there are a lot of patients in our practice, and I had fortune of having these group of patients so I've got, one of the large volumes of patients who are using this, and two, three things which has not been documented in literature, we found in our practice is that in Indian patients, we have found that the LDL cholesterol level goes down even as low as, less than 10 LDL. And quite a few of them, as I was talking to Dr. Pramod, that they say that I don't want to take, any other statin every night, so I want just this drug. And we have seen that in Indian population, even after 6 months after the first dose, the LDL level is significantly lower. So it is not gone beyond 50. So in fact, in few patients we used after 9 months the second dose. So the sustained effect is longer than the usual what has the IFU of the company says. And then quite a large number of patients are without other lipid lowering agents. So the guideline says that you cannot withdraw them or cannot deprive the patients from uses of statin, but those who do not tolerate statin, the data is there that it doesn't cause the other mechanism related significant rise in the LDL cholesterol and doing any harm. So I would say that fear is unfounded.
Thank you, Dr. Viveka. But then after all these things, still there are 20% of the patients who will not achieve the target.
Yeah, absolutely.
So that is there. So new drugs are in pipeline. Who, probably they will help. Thank you, Dr. Viveka, for a very good time.
Thank you.
The next speaker is Dr. Yeah.
Thank you, Dr. Viveka, for such a great talk. And we are living in the era of small interference RNA molecule. And in 2023, Victor Ambros and Gary Rofkun received Nobel Prize for this SARNA and its application. We now have olpasiran and many other drugs which are on there in the development. So with this thing, there is a changing paradigm in lipid management, and I would like to invite the chairperson for this session, Dr. BP Singh sir, Dr. KK Barun sir, Dr. Anupam Bhambani ma'am, Dr. Nirav Kumar, Dr. Vipin Kumar, and Dr. UN Singh.
Good evening, ladies and gentlemen. I welcome you on behalf of the Bihar Intervention Council in this scientific session. The next speaker is Dr. M.K. Das, who doesn't require any introduction in Patna. He has been very familiar. He is the first president of Cardiology Society of India, and he is the sole person who is running the show at the moment, both at the national level and international level. He is a member of the many governing bodies like the Asia Pacific Society. He has been president also, and with the European Society of Cardiology and American College of Cardiology also. He is associated with V.M. Birla Heart Research Center at the Calcutta Medical Research Institute, Calcutta. He doesn't regard that rate MBBS from Dibrugarh and DM Cardiology. One thing I would like to say, he has been topper of the in the free examination whole world now. That in MBBS, MD, DM, many people are there. He is the topper of the free medical university examination in the West Bengal. And he is a very kind gentleman and very simple living. But rather one person who forced the CSI to introduce the guidelines, various documents over a status paper from the CSI on heart failure, lipid lowering, many things. Dr. M.K. Das introduced, and just now you heard Viveka telling about the inclisiran, and then that Dr. Das will be speaking on what is the paradigm shift, not LDL lowering to 100 or 70, where we have to go, what we have to use. Other aspect Dr. Das will tell. Dr. Das, please.
Good evening, everyone. Thanks to Bihar Interventional Council for inviting me for this presentation. And I am also thankful to many people, including Dr. B.P. Singh. You don't know, but I must inform this at this forum because this is a Cardiological Society forum. He was the interim president of CSI for 2 months before I actually took over the function as the president of Cardiological Society of India. I am also thankful to Dr. Vivek Kumar for his beautiful presentation. In fact, my job will be lessened and I'll be focusing more on the newer sites and also give stress on certain guideline factors which are very, very important to know. And that's why I have coined this term, shifting sands of lipid management. I'll focus on more on the guidelines as well as CETP inhibitors and the new treatment horizon. Now, you have been already told that there are certain lipid parameters which are very important for Indians to cause the atherosclerotic cardiovascular disease, which are high LDL level, low HDL level, and elevated triglyceride level. So this triad, and there is another factor that is the lipoprotein A, which forms the quartet, and ultimately they result in more chance of atherosclerotic cardiovascular disease in the form of myocardial infarction or stroke or peripheral arterial disease. We are giving nowadays more stress on peripheral arterial disease because we are diagnosing it more and we can do some interventions. And by taking care of these, actually, we can reduce the stroke pattern or myocardial infarction patterns and peripheral arterial disease. And more the time is elapsed, there will be more chance of developing the various complications of atherosclerosis. And as it has been shown here, there is more increasing incidence of the various cardiovascular disease. And really, it is very much evidence-based that lowering LDL cholesterol is translated to lowering of the incidence of various cardiovascular diseases. And our treatment goal, that's why, should be aggressive LDL cholesterol lowering, especially in the acute coronary syndrome scenario, because these are the patients who do have more chances of this mortality. And this is the guideline which has been published in 2024. It was presented in the December 2023 in All India Conference, the guideline which was formulated by Cardiological Society of India. And we have divided it into different groups: extremely risk, very high risk, then moderate risk and low risk. But what is more to be given stress about is the extremely high risk and very high risk group, where despite giving the combination therapies with various kinds of drugs, which I'll mention just after this slide, then there is need of lowering the LDL cholesterol to lower than even 55 milligram %, which is the standard guideline from all the organizations across the world. And Lipoprotein A, as I have mentioned, this is a very important factor, independent risk factor for acute coronary syndrome, and these are the challenges. Very few effective options are there. Those which were there, they were put in the oblivion because of the side effects. But emerging researchers are showing encouraging results, and I'll talk about that on this particular event. And this is the pattern in India. 25% or 469 million people are actually having the lipoprotein A. That's why we should take care of lipoprotein A in addition to the LDL lowering aspects. Now, these are the various guidelines, CSI, then 2023 ESC, then Lipid Association. All of these focus on lowering the cholesterol level to below 50, and in very high risk patients, of course, you must go even below 40. Now, one point that was asked to Dr. Vivek Kumar, whether we should go further below to 30 or so or not, this is still a controversial issue because of the fact that it has been shown by certain meta-analysis that there is increased chance of mortality if the LDL cholesterol is lowered below 24 or 20. Though inclisiran has got an effect to lower it to further below 10 mg%, but there is a chance of increased mortality because of various other factors which I am not going to detail. Now, statin era was the cornerstone, there is no doubt about that, and therapeutic guidelines for LDL cholesterol reductions are based on certain scores which I have mentioned here, and we must lower it below 55. I am stressing and re-emphasizing on that particular aspects. And intensifying lipid lowering therapy is necessary to optimize lipid levels of patients with atherosclerotic cardiovascular disease, and there are novel drugs and novel targets which are necessary to reduce the atherosclerotic cardiovascular disease risk. There are unmet needs, and very important issue is residual risk. Now, this residual risk may not be only related to LDL cholesterol management. It may not be associated only with the LDL cholesterol. Otherwise, with inclisiran and all, we could attain the lowering of the LDL cholesterol. But why still we are having the restenosis and other things which are happening? So that is called the residual risk, and we must take care of it by other agents like the ezetimibe or even bempedoic acid, which are coming in a big way. And in all the guidelines, the combination therapy, if the single agent is not effective, the combination therapy of the statin plus ezetimibe plus bempedoic acid are recommended. Now, role of PCSK9 has been very much highlighted by Dr. Vivek Kumar, so I am not going into the detail of it, but there are two main important agents. One is the PCSK9 inhibitor, and the other is the inclisiran, which is small siRNA, which acts through the RNA mechanism, and they reduce the production of the PCSK9. On the other hand, PCSK9, they block the receptors. So there is a comparative analysis between the PCSK9 and what is called the beta blocker. So there is down regulation of the receptors in the heart failure. Same way in lipid problem or dyslipidemia problem, there is the receptor that is down regulation, which is taken care of by the PCSK9 inhibitor. So these are the ways by which the siRNA also acts by transcripting the gene, and the inhibition of the PCSK9 is, as I have told, that LDL receptor increases there, and that's how they help in the prevention of, the atherosclerotic cardiovascular disease and recurrence. these are some of the trials which have been shown, Orient 9, Orient 10, Orient 11, which over a period of time, they have shown that they do result in lowering of the restenosis or reinfarction. Now, Orient 8 demonstrated long-term safety, and Orient 10, 11, they showed both safety and efficacy with the PCSK9 inhibitors or siRNA. Now, what is important to note that with PCSK9 inhibitor, you can treat even the multi-vessel disease effectively, as it has been shown here, that they lower the primary endpoints, and they overall also they lower the recurrence or the incidence of multivascular disease. Now, this recurrent coronary events, which is a very, very important problem for all the interventionalists. You have given adequate stent, you have used the drug-eluting balloon, but the patient after 6 months or even within 6 months, sometimes they are coming back. It's a quite embarrassing situation. So here, actually, the plaque progression is very, very important, which can, and also the effect of stent failure and small disease may be present, still present in the patients, where you can take the help of the PCSK9 inhibitor for polyvascular disease. Now, this LPA, as I was highlighting, that it is a quite a remarkable problem, and we should take care of it. And it has been shown that the various the interventions which have been started recently with the trials, but they have not been translated into the guideline yet. But they are showing good results, and very promising results with the LPA inhibiting agents like CETP inhibitor. And in ACC 2025 ACS guidelines, they have specifically mentioned about this, the recommendation of the inclisiran as a class 1 recommendation. Now, this is a comeback story for CETP inhibitors, and CETP actually they increase the HDL cholesterol, so that's how it has the chance of preventing the recurrence or reducing the residual stenosis or residual effects. But what was problem with the particular molecule, that torcetratrib, which was very commonly used that time initially, but they came into oblivion because of the fact that it was causing higher incidence of liver dysfunction and liver failure. So later on, from 2010 onwards, the various other drugs that have been taken into account are dalcitabine, then obicetrapib, then anacetrapib, and the latest one is the TA8995, which are almost in the last two, the anacetrapib and TA895, they are in the phase 3 trial, but the other trials, they are showing the good results. Good results with the CETP inhibitors. So the future landscape of lipid therapy should be beyond LDL cholesterol. And LPA lowering is very, very encouraging sort of management issue. And as I have mentioned, that certain drugs which are coming in the forefront. Apart from this, the pelacarsen, then QJ230, these are coming in the form of the LPA lowering therapy. Now, apart from this, inflammation is very, very important, which is again coming in a very big way, and they are being tried like colchicine and ziltivekimab, which are being used as an anti-inflammatory agent. And since the atherosclerotic cardiovascular disease is attributed to be due to the inflammation, so they are showing some good results. In acute myocardial infarction setup or ACS setup, ACS colchicine, the stable coronary artery disease, colchicine was showing good results, but not with the other ones, ACS. So now they are being tried. And combination therapy also is with the multifaceted treatment for comprehensively lowering the risk reduction. And last but not the least is the AI, artificial intelligence, which is coming in a very, very big way to specify the therapy and to attribute the very, very specific therapy known as personalized medicine or personalized care of therapy. So to conclude, the take-home message, which is actually I have borrowed it from CSI guideline itself. For the treating physician, the executive summary explored that the treatment should be earlier, and the earlier it is better. The lower it is better. Longer the better. Together the better. So these consensus guidelines cannot replace, I am re-emphasizing on that cannot replace the individual clinical judgment who remains the sole arbiter in the management of the patient. Thank you very much for patient hearing.
Thank you, Dr. Das, for your brilliant talk on the subject. You reviewed all the things. Thank you. One question. Oral 3CSK9 inhibitor. Can you say anything?
Sorry?
Oral 3CSK9 inhibitor.
Oral PCSK9 inhibitor is coming. But
Coming within a year or two.
Yeah. But the thing is that we personally don't have any experience. Whatever
No, but it had not come in the market.
It is coming.
But results are very good with the oral 3CSK9 inhibitor. Phase 2 we have study done, and the results are very good.
Right.
After phase 3 a study or that a study will come. Thank you. Another you want to?
Thank you, sir. Thank you, sir. As usual, it was a very enlightening talk. So, during all this, during the course of development of lipid-lowering drugs, all the new drugs like anti-inflammatories and PCSK9 all gained momentum, but fibrates, initially they were introduced as expected drug, especially in the context of Indian dyslipidemia with high triglycerides, but they did not gain their position and did not. So what is your take on that? Do they really have a role in Indian dyslipidemia, or they have lost their...
No, I have not mentioned this triglyceride management because of the time factor, but definitely it has not lost its role. It is still there, and even in the guideline of the CSI guideline specifically, the triglyceride management is well mentioned. And lot of therapeutic measures which are there, that includes the fibrate as well. But as you know that the fibrate also has got certain complications, especially when it is combined with the statin, there is increased chance of myopathy. So that is to some extent avoided, and other drugs which are coming again, the various UMAB, these antibodies, RNA inhibitors and all, they are also coming in a big way for the triglyceride level lowering. But fibrate is still used, especially when the triglyceride level is significantly high. The reason is why we have not put it in the very forefront, because in males the roles are not very much high, but in females there is definitely a role of triglyceride in the atherosclerotic cardiovascular disease. That's why in females you can use it, and it is in fact used.
Any question from the audience? Anu Babu?
Thank you, Dr. Das, for your brilliant talk.
So great talk, Dr. M.K. Das, sir. And moving on to the most important aspect of interventional cardiology is primary PCI. And when we are talking about primary PCI, we need to see the role of antiplatelet therapy. And nowadays, I think Cangrelor has got its own place, and we would like to hear Dr. Pramod sir's view on that regarding the usefulness of Cangrelor in primary PCI. So I would like to invite the chairpersons, Dr. Arvind Kumar sir, Dr. Sandeep Kumar sir, Dr. Avinav Bhagat, Dr. Vikas Singh, Dr. Rajiv Krishna, and Dr. Anup Singh.
Thank you. Dr. Pramod Kumar sir need no introduction, but I am extremely privileged as a quorum. I have to introduce him. Dr. Pramod sir, very few people or most of the people knows that the first angiography in Bihar was done by Dr. Pramod Kumar sir in 1998 when first cath lab was established in Jivak Heart Hospital by Dr. Ajit Pradhan. So it's very few people. And after that, he started so many first. He established cath lab in Paras Hospital. He established cath lab in Medanta, where presently he is the head of the department of cardiology and director. He is from GB Pant Hospital, most prestigious hospitals. He has done his DM. And he was awarded the best case award at the prestigious TCT conference in San Francisco, USA in 2014. His name was there in Time Personality of the Year and in 19. And the Cardiological Society of India, as an honor, has honored him with the Bihar Lifetime Achievement Award in one of the conferences of CSI Bihar chapter. With this very small introduction, he has done so many, he has a vast experience in doing radial primary angioplasty through radial route. In fact, he is the master in radial angioplasty. Sir, it's very short introduction. May I request you to please come and deliver your talk.
Thank you. Thank you very much. Thank you, Bihar Intervention Council, and thank you, Arvind, for those very kind words. So if you have not listened to Viveka and Dr. Das, and you have still landed in my cath lab, whether I should give you Cangrelor or not. So I must confess right at the beginning that there isn't much to talk about Cangrelor. It's not a great molecule. It's not really a great molecule. When we started, Viveka will remember, when we were working together in Max, we were part of a study of Cangrelor. But it took a real long time for it to show some real effect, some real clinical benefits. Can I go to the next slide, please? Okay. So right at the outset, let me tell you what is the status of Cangrelor as far as the guidelines are concerned. So this is the ACC-HA guidelines on ACS published in February, and it says that it's a 2B indication, which is just above class 3. So among patients with ACS undergoing PCI who have not received a P2Y12 inhibitor, intravenous Cangrelor may be reasonable to reduce peri-procedural ischemic events. So it may be. So, you know, when it came, it was again a very expensive molecule, and we thought that it will completely inhibit the platelets and the ischemic events will come to a very low level. But it has its drawbacks. So Cangrelor is a direct-acting intravenous P2Y12 receptor inhibitor characterized by rapid and potent platelet inhibitory effects, and the platelet functions are restored within 1 hour of its discontinuation. It has only been compared to clopidogrel or placebo in 3 randomized trials. It has not been compared against ticagrelor or prasugrel. And those 3 trials, the pooled analysis showed that it reduces peri-procedural ischemic events, but there is a definite flip side that the minor bleedings are increased. How do you change from once you have stopped it? What do? You can start any of these drugs, clopidogrel and prasugrel, after you have stopped the infusion, but ticagrelor can be given any time. So where does it have a role to play? And this was the only trial which actually tilted the whole thing in favor of Cangrelor was the Champion Phoenix trial, where it definitely showed that there is a statistically significant reduction in the event rate in patients who were given cangrelor, and this was seen at the end of 48 hours. 5 to 6% of what are the scenarios where it might be useful? This is what I am going to tell you. So 5 to 6% of acute MI present with cardiac arrest, and almost 64% of these are unconscious or are on ventilator. A lot of them will have vomiting or are sedated, where absorption of oral medication will be very poor. Now, this is a study proved, thing that patients who are not able to take orally, using prasugrel or ticagrelor, there was a time when the company advocated that you make a paste of ticagrelor and give it, but it has been shown that it really doesn't work. So in those situations where you cannot give orally, cangrelor is a very efficient antiplatelet agent. There is absolutely no doubt about it. There is another indication which is not yet approved, is that it can be used as a bridge trial. In fact, the name of the trial was Bridge trial. It was published in 2013, where if you think after the angiogram that this patient needs CABG, and you have done, let's say, infarct-related artery angioplasty or something, and you feel that the patient should be on strong antiplatelet agents because of the ongoing ischemia. So this drug can actually be given over a long period of time, and then the patient can go for surgery, because once you stop it, the effect is completely disappears in 1 hour. So this is something which we have used certain times, not a very frequent usage. In fact, most of the time when cangrelor was not available, we used to use tirofiban for giving over a long period of time. Even tirofiban, if you stop it, the effect disappears in about 6 to 8 hours. So then you can actually, the surgeons are more confident, and otherwise if you have loaded them with oral, they are really, we have seen those bleeding episodes happening in patients who were loaded with loaded with ticagrelor or clopidogrel. If you have given prasugrel, they will never touch those patients for at least 5 to 6 days. So this is a very limited indication of using cangrelor. So at present, its use is limited to situations where oral P2Y12 inhibitors absorption is impaired or not possible, and immediate antiplatelet activity is required. Let's say in case of CABG or some another surgery is required, when prolonged discontinuation of a P2Y12 inhibitor may not be safe, and you want to have a very strong antiplatelet activity in patients who have an ongoing ischemia. So this is one patient. How do I play this? Can I play this? Yeah. So this is a patient who just came 3 days back, ongoing angina with massive ST depressions, and you see this is the angiogram. LAD is completely blocked. There is a very large circumflex which gives rise to 2 OMs. Both of them are very, very tightly blocked, and the flow is not very good. Next one, please. Next one. Yeah, play this, please. And this is his right. You can see here the PD is a significant vessel which is very tightly blocked. So we gave cangrelor to this patient, which we continued for about 4 or 5 hours. By the time the OT got ready, the surgeon, we have a very good surgical team, and they were willing to take him immediately. So we put him on cangrelor, continued it for about 4 hours. By the time OT was ready, the blood was arranged, we stopped it. After that, he underwent surgery, and he's doing fine. He is off ventilator, he is off IABP. And so this is a very limited indication, but it's a very important indication where if you have a patient, a situation like this, cangrelor is something which can be of great help to you. So what we do in our lab, as I told you, as soon as we know the full anatomy, and if CABG is strongly indicated, we load with aspirin and start either cangrelor or tirofiban. If we feel that PTCA2 infarct-related artery is indicated because of ongoing ischemia, we'll only do a ballooning, may not stent it, preferably not stent it. And then we send those patients within 24 to 48 hours for CABG. And most of the time, 95% of the time, the surgical team in our hospital is willing to take such patients, and they have come out with good results. So this is what we do. Thank you very much. In fact, I would like to listen to your experience with Cangrelor, Viveka, Dr. Das, and everybody who is present here, how often you use it, and Sanjeev is here. Will he be ready to take such patients for CABG? Sanjeev. He's the head of cardiac surgery at AIMS Patna.
Actually, till now we have not come across any patient who is on triglyceride. So Dr. Anupam Bhamani is here. Better she can say whether they are using in cath lab or not.
Okay.
Indications where surgery is contemplated in immediate future rather, so definitely it has a theoretical role, but cost constraints will always be there.
Of course.
Yeah, so definitely when in such situation it can be a very useful agent.
I'll request Viveka to, what's his practice? He comes from a very busy lab, very, very busy lab, and they do all kind of bad cases.
Yeah, so I think it has a place, as you rightly said, that the indication is quite useful and unique in the sense that because we have multi-speciality hospital also. So not only the CABG, but a lot of patients where you have done multivessel stenting and all, and then, after, because maybe 3-4 days or a week patient started having GI bleed and all, and on investigation you find that the patient had CA colon. So in fact, there is a joke going on that cardiologists have diagnosed more CA colons than the than the surgeon themselves, because they will give a challenge of antiplatelet and anticoagulation, and those are the cases where you have to stop the antiplatelet. So we use a lot for the bridge therapy. So our uses of Cangrelor is number one in there. And then in patients who have got acute coronary syndrome, where they are intubated, shock-like condition, where you can't really rely on the oral absorption of even the fastest acting drug like Prasugrel and Ticagrelor. So we use more often with Ticagrelor because you don't have to wait for timeline, because Prasugrel and Clopidogrel has to be given once the Cangrelor infusion is over. But for the Ticagrelor, you can give it right away, even before the patient has been started. In fact, there are few cases where the patient had been loaded with these, and then we have used if the patient had slow flow, no flow kind of situation also. So on there we have used, and then many times you would have seen that the patient has come with acute myocardial infarction, and then the moment you wired and he had vomited. So all the antiplatelets have gone in a reverse direction. So you give Cangrelor and then go ahead and do the procedure. So I think it has a niche use, but in a place where, so we use it almost 10-12 vials in a month, so that's our usage.
Yeah, I won't say we tend to, but I mean there are always such patients where we use. It's a nice drug to have on the shelf because it definitely takes care of those very situations where you can't use anything else. Yeah, Neeraj.
I have used this molecule quite and I'm using it for the last 3 years. And in most of the primary cases where the patient has come very early, even it has been loaded with Ticagrelor, and I find it a huge burden of thrombus, I use this molecule. And it definitely helps with not much of problems in bleeding or even in hematoma. Most of the patients who are on ventilator or who has been in hemodynamic instability, this molecule I use quite often. Even if the patient has been stable and loaded within half an hour, that we don't expect that Ticagrelor has full effect yet, then I use this molecule in primaries.
Yeah, so it's a yeah.
Your patient, your patient who had a CABG, did you give him heparin as well or not?
Always. I mean, when we start the angiogram, the heparin is always given.
Yeah, that's that. But did you continue heparin infusion?
No, we don't do that.
I'm actually from Dr. Neeraj. My son, who is in USA, is working in invasive cardiology. Now, many a days when he comes from the primary PCI at late nights and he talks to me, he says in most of the patients who are coming with cardiogenic shock or cardiac arrest or who has got a lot of thrombus, they are regularly using cangrelor. I do not know. I don't have any personal experience. I won't comment on that. But this is what is being practiced in their hospital.
Yeah. So, I'm not saying that it doesn't have any role to play. But you see this trial with this guideline, which has come only in February, I'm sure, and let me tell you, as I was telling you that we were part of the trial that was almost 15 years back. It has not been able to really establish itself as a frontline antiplatelet drug because of the fact that, if the patient is not very sick and you can give oral antiplatelets, most of these drugs, both prasugrel and ticagrelor, start working within 1 hour. Most of them, they start their platelet activity. I won't say that go up to 70 to 90% of suppression of platelet, but within half hour to 1 hour, especially prasugrel, it starts working. They will have 40 to 50% platelet suppression, which is very good.
Is it safe to use this molecule after thrombolytic therapy with tenecteplase?
No, there are absolutely no. None of the IV antiplatelets should be used after thrombolysis. None of them.
Sir, we have used in 2 cases. One patient was in acute cardiogenic shock where gastric absorption of drug is impaired. That is the main reason. The other patient for bridge therapy who underwent CABG, and that also for an infusion 0.7 into body weight into 60/200. We don't give a loading therapy in a bridge therapy, infusion therapy, and just stop the morning of the day when he is going to undergo the surgery, and it had good result without any bleeding. So I think it's a good in STEMI patient where you can't stop antiplatelet medicines. So I think scenario.
I agree. I am not saying that, but for some reason, it has not been able to promote itself to more than 2 weeks. So because the trials
was for routine, most of the patients, or in specific scenario, I think in these scenarios.
FDA has not approved it for bridge therapy. Okay. There is no approval.
Yeah, for this thing for acute cardiogenic shock and all, has it been tested in these scenario?
No, it has not been. No, the Champion Phoenix trial was basically on NSTMI and STMI.
No,
all the cases.
That is what I'm telling you. If there will be data in patients where gastric absorption is impaired, like cardiogenic shock, ventilator.
That is an indication. That is an accepted indication. But more than that, whether it will have an extra benefit in cardiogenic shock or not, we don't know. Thank you. Thank you very much. Because of the 3 trials, because of out of those 3, 2 trials were negative actually. And again, mind you, it was not tested against ticagrelor or prasugrel. There has been no study where it has been tested against. And these 2 are very potent antiplatelets. That is probably one of the reasons why no further trial has been done. So whatever trial has been done, it has been able to find a place in interventional lab based on those trials only. There is no further, study on this molecule, so we don't know.
Yeah, we have some experience from CMC Vellore. We have done actually platelet studies and using Verify now. And it's a very niche subset, like Ashish pointed out, where you're in cardiogenic shock when a perfusion is less gastric emptying. So the molecules which we looked at is we studied clopidogrel, integral, we studied crushed, we studied ticagrelor and integral, and we studied crushed ticagrelor. Of this, like Dr. Pramod alluded to, ticagrelor is superb, in terms of clopidogrel. Clopidogrel, when you crush it, actually it works worse when you give it, because it needs a pH where, for instance, it's a prodrug. Whereas it comes to ticagrelor, the crushed ticagrelor is even better than integral ticagrelor, because finally when you look at 1 hour, rightly you said 1 hour or 30 minutes, the platelet inhibition almost reached 3%. patient non-responders is 3%, whereas compared to almost 30% with clopidogrel. So coming to cangrelor, like you said, the evidence is lacking in terms of when you use it. The most indication which we have used is used to bridge during surgery. Even then, there's a lot of Indian data is not there. We really don't know how long. But you again stop the antiplatelet 5 days before, and you start this infusion around 6 hours before, and then the neurosurgeons, especially when it comes to this. So I think in terms of like extraordinary cases, or cases where you just cannot, you might, but frequent testing is what is recommended. So I don't think it's a standard case with a lot of thrombus, you should be running towards IV cangrelor. Thank you.
Yeah, even if you see the guidelines on IV antiplatelets, GP2B3A, it's a class 3 indication now for routine use in primary. The only thing is that it's a class 3A, that means no harm, but there is no benefit. That's what it says, 3A. The only, if you read the whole chapter, you will find that it is mentioned at the end of that, paragraph, that these drugs may be used when you have a very high thrombus load. That's all. Anyway, thank you very much.
Thank you, Dr. Pramod sir. It was a great talk and great discussion by everyone. We learned many things, and I hope it's a great beginning for tomorrow's session. Tomorrow we are going to have a packed session. The session will start at 8:30, so I would like to request everyone to be there by 8. So thank you all. Thank you everyone for being here. And because everyone is coming at 8, so breakfast, we will have breakfast together at 8 a.m. So we are having dinner in nearby hall. In Chanakya Hall. So please, everyone is invited for that dinner. Thank you.